This technique will discuss central line placement of a long-term catheter using the Guidewire technique using the following supplies. Central lines are very useful for patients who will be in hospital for multiple days, for those requiring multiple blood sampling, infusion of hyperosmolar fluids, or those patients who require central venous pressure measurement. A needle is inserted into the vessel. If you feel uncomfortable with further manipulations that are required to place the catheter, then an over-the-needle catheter can be used instead of the hypodermic needle. Once the needle is in the vessel, a J-wire is inserted through the needle and into the vessel. This wire is retracted back into its sheath and then inserted through the needle and into the vessel. The J on the end of this wire spreads the walls of the vessels apart, which facilitates insertion of the wire into the vessel. In some of our smaller patients, the J is a little large for insertion into the vessel, in which case the wire should be turned around and the straight end inserted. Once the wire is in the vessel, the catheter is inserted over top of the wire and then will be secured in place. A needleless injection cap is inserted over the end of the catheter. This prevents fluid movement in or out of the catheter until the central blue valve is depressed. The needleless injection cap is then capped. All necessary supplies come with the kit. If this catheter is too long, it can be placed a little shorter and a blue or white wing inserted over top of the catheter to be able to suture the catheter at the venotomy site. The animal is clipped, surgically prepped, and drapes are placed. The drapes are being left off for visualization purposes. The clip should extend from the dorsal midline to lateral to the ventral midline and from the angle of the mandible to the thoracic inlet. When holding off the jugular vein, care should be taken to ensure that the index finger depresses directly into the thoracic inlet rather than retracting the skin caudally at the same time, which will flatten the vessel. The jugular vein runs from the angle of the mandible to the thoracic inlet in a straight line. This location is maintained no matter what position the animal's head is in. The catheter is pre-measured to an appropriate length, which is approximately the fourth intercostal space when using the jugular vein in order that central venous pressure measurement can be done. An imaginary line is drawn from the caudal aspect of the elbow with the limb in a neutral position up to a level that is in line with the venotomy site. The vessel is punctured by puncturing through the skin first and then puncturing the vessel. The jugular vein has a tendency to roll. This will facilitate puncture of the vein. Flashback should be seen through the hub of the needle, except in the most hypovolemic patients. The wire is then inserted into the vessel. It should proceed without any kind of resistance. If resistance is perceived, then the needle or the catheter is not in the jugular vein, but is in the perivascular tissues. The wire is inserted such that once further manipulations are performed, the wire will not fall out of the vessel. Once it's inserted to an appropriate level, the sheath is removed, followed by the stylet or the catheter. The wire should be stabilized during this procedure to ensure that it does not retract. The catheter is then threaded onto the wire and inserted into the vessel. Care must be taken to ensure that some part of the wire is always able to be held. If the wire has been inserted too far into the vessel, it should be retracted until it is seen coming from the hub of the catheter. Using a rotating action with the thumb and forefinger down near the skin site, the catheter is then inserted into the vessel. Minor force may be required to get it through the skin and the subcutaneous tissues. It will follow the path of the wire, and there should be no concern with this process. The catheter is then inserted to the pre-measured level. The catheter is flushed to ensure no clots and aspirated to ensure that blood can be retrieved. A needleless injection cap as well as a cap are inserted. The catheter is sutured to the skin using a monofilament suture material. For additional security, an additional suture can be placed around the distal suture groove and into the skin. Prior to bandaging, the site should be cleaned up and all blood removed. Broad-spectrum antibiotic ointment should be placed over the venotomy site if desired. Sterile Telfa pad or sterile 4x4 should be placed over the site, and a light dressing should be placed. Sterility should be maintained during this process. Care should be taken when placing a circumferential neck dressing to ensure that the dressing is not on too tight, as this can occlude venous flow and the airway. In order to prevent having to use a circumferential dressing, a patch dressing can be placed. The Telfa pads are followed by sterile 4x4s and then elasticon, which is stapled to the skin. When dressing changes are required to inspect the venotomy site, 2 cuts can be made in the elasticon to create a flap. The 4x4s are removed, followed by any Telfa pad. The site can be inspected, cleaned, and a new sterile dressing can be placed. The flap is then placed back in its normal position, and a new piece of tape is placed over top to hold it in place. If the catheter is too long, then a blue or white wing is placed at the venotomy site. There's a longitudinal groove here that allows the wing to snap easily onto the catheter, and there are 2 other suture grooves that must be sutured in order to hold this wing in place over top of the catheter. It's very important to suture at the venotomy site, as these catheters will have a tendency to back out if they are not sutured at the skin puncture site. Therefore, once again, if this catheter is too long, a blue or white wing should be placed on here and then sutured to both the skin, and sutures should be placed around the grooves holding the catheter to the wing. Occasionally, catheters become dysfunctional and may need to be replaced. The advantage of this kind of catheter is that an over-the-wire catheter exchange can be performed. A new catheter is opened, and the wire is inserted through the old catheter. The old catheter is then removed, leaving the wire in the vessel. Again, care must be taken to ensure that the wire can be held at all times. A new sterile catheter is then inserted over top of the wire and into the vessel. Again, a rotating action at the skin site will facilitate placement of the catheter through the skin and subcutaneous tissues. These catheters come as single lumen, double lumen, or triple lumen catheters. All catheters are placed in a similar fashion.